Good evening, guys, and today we will discuss about the glomerular filtration rate in detail. And this is the part 3 of the session we are discussing. So let's get started. The GFR depends on two things, as we have discussed, is the net filtration pressure, and the second one is the filtration coefficient, net filtration pressure, and Kf, the filtration coefficient. The Kf further depends on two things, the hydraulic conductivity. The hydraulic conductivity is also known as the permeability and the surface area. This session we are discussing about the net filtration pressure. Net filtration pressure has four components, you can say, or it depends on four things. First is the capillary hydrostatic pressure. Okay. The second is the oncotic pressure in the bowman space. It means that the protein present in the bowman space. Capillary oncotic pressure, the protein present inside the blood capillaries. And the fourth is the bowman's hydrostatic pressure. Okay, so following this diagram, we can see that capillary hydrostatic pressure is a favoring force for the filtration, and the oncotic pressure in the bowman space is also a favoring filtration force. Okay, the hydrostatic pressure in the bowman space and the capillary oncotic pressure both are opposing forces. And by calculating these, the capillary hydrostatic pressure is 50. Okay, and the oncotic pressure in the bowman space is 0 practically because there are no protein inside the bowman space, and the capillary oncotic pressure is about 30 mmHg, and the hydrostatic pressure in the bowman space is 10. So the forces favoring filtration are 50 and forces opposing filtration are 40. So 50 minus 40 under normal physiological condition is 10. It means that the filtration is occurring inside the bowman space easily in the physiological conditions. Okay. In the filtration coefficient remains stable because the permeability and the surface area do not change significantly throughout the time, but net filtration pressure can change frequently because it depends on these four pressures, and these four pressures can change in case of diseases. So we can say that the GFR is directly proportional to the net filtration pressure, but it is also directly proportional to filtration coefficient, but less significantly. So let's discuss these pressures individually. First of all is the capillary hydrostatic pressure. It is about 50 mmHg, and if it is increased in case of increased blood flow to the glomerulus. It means in case of hypertension or increased pressure flow of the blood towards the glomerulus, the hydrostatic pressure increases. In case of dilation of the arterioles, okay, and it is a favoring force, so net filtration pressure increases, so subsequently GFR also increases. The second is the oncotic pressure in the bowman space. Practically there are no proteins present in the bowman space, but if there are proteins present in the bowman space, this oncotic pressure in the bowman space can increase from 0 to some value in case of nephrotic syndrome, so it is a favoring force for filtration, so net filtration pressure increases and GFR will also increase. The third is the capillary oncotic pressure. It is due to the proteins of the plasma present in the blood in case of hyperproteinemia or dehydration, in which the blood become concentrated. So this capillary oncotic pressure increases and it pulls the water. It means that it is not a favoring force for filtration, it is an opposing force, so GFR will decrease accordingly. And hydrostatic pressure in the bowman space, how it can be increased? For example, this is a nephron. Okay, I will draw a nephron roughly. This is the proximal convoluted tubule, and these are the loop of Henle and the distal convoluted tubules. Okay, it's just not anatomical correct, but it's just for understanding. If there is obstruction here, okay, if there's any obstruction in any point in the urinary tract, or if there is obstruction in the ureters or in the urethra or urinary bladder, the pressure can build up right here in the bowman space. If there is obstruction in the renal pelvis, ureter, urinary bladder, or urethra, in case of urolithiasis, kidney stones are formed. So it leads to pressure buildup inside the nephron or the bowman space. In this condition, the bowman's hydrostatic pressure will increase, so it will decrease the filtration. It will affect the filtration. Okay, this the same thing is written that urine will accumulate upstream, so it will increase the bowman's hydrostatic pressure. If the obstruction is severe, in case of post-renal failure, the obstruction is a type of post-renal failure. It leads to the complete renal failure, so we can suffer from kidney failure, and there is no formation of urine in that case. There are three kinds of renal failure as far as we are in the discussion. The pre-renal failure, it means that something is happening before the kidney. Before kidney means that it can happen in the blood. For example, in case of inadequate blood flow towards the kidney, in case of severe circulatory shocks, hypotension, no blood is flowing towards the kidney. So it is the pre-renal failure. Okay, intrinsic renal failure means that something is happening inside the kidney. The damage is within the kidney. For example, glomerular or tubular dysfunctions. And post-renal failure is the obstruction in the urinary system. As we have discussed, that obstruction leads to the urine buildup upstream, and it can affect the filtration rate. These three are the types of the renal failure, and these all three leads to decrease in GFR. Okay, as far as we are in the discussion, we can discuss these pressure individually. First, we will discuss about the colloid osmotic pressure. We have not discussed colloid osmotic pressure. It is nothing but the oncotic pressure of the plasma. Colloid osmotic or oncotic are the same things. It is the capillary oncotic pressure, which is due to the proteins, plasma proteins that are present in the blood, and this is an anti-filtration force. The value for this force is, or pressure is, 30 millimeter of mercury. And this pressure depends on two things. First of all, because it is due to the plasma proteins, it will depend on plasma proteins obviously. And the second is the filtration fraction. We'll discuss them one by one. First of all is the proteins. Okay, I have written like this because it is inversely proportional to the GFR. It is an anti-filtration force, okay, anti-filtration pressure. Hyperproteinemia and hypoproteinemia. Think logically that if there are large number of proteins inside the blood, so this pressure will increase and the GFR will decrease. And if there is hypoproteinemia, less amount of proteins are present in the blood, so the pressure will decrease and GFR will increase. So this is in condition case of hypo and hyperproteinemia. First of all, what can be the cause for hypoproteinemia? Hypoproteinemia can be due to several causes, but I will discuss here the most important one, that in case of protein energy malnutrition, it means that child or a person is not taking adequate amount of proteins as they are needed for the body. In case of diseases, for example, kwashiorkor and marasmus, these two are protein malnutrition disorders in the children. For example, in the countries like Africa, there is not enough protein available in the diet, so the child can suffer from these two disorders. Protein losing enteropathies, it means that something is damaged in the GIT. GIT problems can lead to the protein loss. So the proteins are not properly absorbed from the GIT, so it leads to hypoproteinemia. The third is the liver cirrhosis. In case of liver cirrhosis, the liver become dysfunction and a lot of proteins are synthesized from the liver. So the main factory for the manufacturing of protein is not working. So synthesis of protein will decrease and it eventually leads to hypoproteinemia. Fourth is the protein losing nephropathies. In case of nephrotic syndrome, the permeability of the glomerular basement membrane increases and the protein present in the blood are filtered because of the increased permeability, and it leads to the loss of proteins in the urine. So all these conditions leads to decrease in the plasma oncotic pressure, and it leads to increase in the GFR because it was anti-filtration pressure. What can be the cause of hyperproteinemia? The one and only, not one and only, but the most important cause for hyperproteinemia is the multiple myeloma. It is a disease of the plasma cells in which abnormal types of plasma cells starts to produce myeloma proteins. Normally, plasma cells are most differentiated B cells, okay, and they produce gamma globulins. These are antibodies. But in case of multiple myeloma, these plasma cells starts to produce myeloma proteins. They start to produce abnormal immunoglobulins that start to deposit in different tissues, and the amount of protein in the blood will increase. It leads to increase in viscosity of the blood, and it leads to concentration of protein inside the blood. So the pressure, oncotic pressure increases and the GFR will decrease accordingly. What is the filtration fraction? First, it depended on plasma protein level, and the second, the colloid osmotic pressure depends on the filtration fraction. What is filtration fraction? The most easiest definition for the filtration fraction is that the amount of plasma that is filtered in the glomerular capillaries. It's the called filtration fraction. So let's discuss about filtration fraction more in detail because it's also affecting the oncotic pressure. First of all, it's an afferent arteriole and it's the efferent arteriole. The blood is moving from afferent to efferent arteriole in this direction, okay? And the plasma is filtered from in the glomerular capillaries. First of all, we take the average value for the plasma oncotic pressure is 30, but this is not the actual case. In the afferent arteriole, the plasma oncotic pressure is 28, and at the end of the filtration process, the plasma oncotic pressure is 32. Why it is increased? It is because that the plasma is filtered here, okay? The fluid is filtered, but the proteins are not filtered. As you all know that proteins have the higher size, larger size uh, than the pores present in the endothelium of the capillaries. So these proteins cannot be filtered except in the conditions when there is high permeability of glomerular basement membrane. But under physiological conditions, these proteins remain inside the plasma. They are not filtered. So the fraction of the plasma is filtered, but the proteins are remaining here. Eventually, in this context, the concentration of protein starts to build up here, starts to increase. It means that towards the end of the filtration, the concentration of the protein increases. It means that the plasma oncotic pressure in the remaining fluid will increase, and it leads to decreased filtration. As you can see that filtration is decreasing towards the efferent arteriole, and the protein concentration is increasing towards the efferent arteriole. It is logical to think because the filtration reduces because the protein concentrations is increasing towards the efferent end of the arteriole. Okay, the same the same thing is written here that in the afferent arteriole, the oncotic pressure is 28. It means that fractional amount of protein and the plasma is present. But as the filtration proceeds, the remaining plasma become concentrated with the proteins, and it means that the plasma oncotic pressure with the filtration process going on will start to increase. Okay, filtration factor increases. It means that a large amount of plasma is filtered, more fluid is filtered. It means that more concentrating the remaining plasma with protein. It means that when we increase the filtration fraction practically or experimentally or any kind of disorder, the glomerular filtration rate will decrease. It will decrease the filtration, and when the filtration fraction is reduced due to any condition, the less amount of plasma is filtered, and the remaining plasma will be less concentrated with the proteins. And it means that plasma oncotic pressure will increase less, and the filtration will be more. Okay, I hope you understand this diagram and think logically about this. The second pressure is capillary hydrostatic pressure. It is a favoring pressure and it has a value of 50 mmHg. What factors are influencing the capillary hydrostatic pressure? First is the systemic blood pressure, and the second is the afferent arteriole, and the third is the efferent arteriole. First, systemic blood pressure. In case of hypertension, when the blood pressure in the systemic blood vessels increases, it leads to increase in the capillary hydrostatic pressure and increase in the GFR. But in case of hypertension or hypotension, the kidney has autoregulatory mechanisms. We will discuss it later, but the kidney starts to autoregulate these kind of filtration processes. The second is the afferent arteriole. Afferent arteriole constriction or dilation. Think logically that if the afferent arteriole is being constricted due to any reason, the pressure inside the capillary will decrease. It means that GFR will also decrease. Okay, and the most important constrictors are epinephrine, norepinephrine, and endothelin. Epinephrine and norepinephrine are produced in response to the systemic sympathetic response, and the afferent arterioles have alpha 1 adrenergic receptors on their walls, so they respond to the epinephrine and norepinephrine and starts to constrict. Okay, and endothelin is produced locally. Endothelin is also produced from the afferent endothelium, and the amount of the endothelin increases in acute and chronic renal failure and in case of the pregnancy induced hypertension. The most important thing here to remember is that pregnancy induced hypertension is also known as eclampsia, and eclampsia occurs mostly in starting trimesters of the pregnancy. Okay, the second thing is that afferent arterioles can also dilate. If they are dilated, the blood pressure here, the hydrostatic pressure will reduced. Okay, and in case of dilation, the resistance is reduced and the pressure will build up here, and it will increase the GFR. Because of dilation, large amount of blood will pour into the glomerulus, and so it will favor the pressure and it will favor the filtration. Okay, the important dilators are nitric oxide NO. Okay, these are produced locally, bradykinin and prostaglandins E2 and I2. These three are the locally produced dilators of the efferent arteriole, and these all can increases the GFR. There is an clinical scenario that, for example, if a patient is suffering from hypovolemic shock or circulatory shock or cardiac failure, in all these conditions there is sympathetic response in the body. It means that in case of sympathetic response, the adrenal gland will start to release epinephrine and norepinephrine, and they will constrict the afferent arteriole. So if the afferent arterioles are constricted so much, it will reduces the GFR, and there is the risk for the renal failure in this condition. But in these conditions, the kidney has autoregulatory mechanisms, and they will release prostaglandins. Okay, but the most important thing here to remember is that if you give such patients NSAIDs, NSAIDs are non-steroidal anti-inflammatory drugs. It means that these drugs inhibit the production of prostaglandins. It means that these drugs inhibit the production of dilators. They interfere with cyclooxygenase enzyme, and they will inhibit the production of prostaglandins. In these circumstances, you need to avoid giving such patients NSAIDs, anti-inflammatory drugs which are steroid dependent. A nitric oxide, bradykinin, and prostaglandins E2 and I2 are locally produced important dilators. Let's talk about efferent arteriole. Efferent arteriole has two circumstances. It can either be dilated or it can either be constricted. So, first of all, let's discuss about dilation. If we dilate the efferent arteriole, if we are dilating the efferent arteriole, it means that pressure inside the capillary will start to decrease. Okay, if we dilate here, the pressure, the hydrostatic pressure of the capillaries will start to decrease, and it will decrease the GFR. And most important dilators are those drugs that block the action of angiotensin 2. Angiotensin 2 is a important constrictor, but the drugs that block the action of angiotensin 2 will automatically dilate the arteriole, and the pressure inside the capillary will decrease drastically, and it will reduces the GFR. But in case of constriction, you would expect that constriction will lead to increase in the GFR, but scenario is different. Constriction, when we constrict the efferent arteriole moderately, it means that severe constriction is not happening here. Moderate constriction will increase the pressure, and it will eventually increases the GFR. But when we severely constrict the efferent arteriole, the hydrostatic pressure in the capillary will increase so much that it will cause an increase in the filtration fraction, and a lot amount of plasma is filtered. So it means that the remaining plasma will be concentrated with the proteins, and it will cause increase in the plasma oncotic pressure. So eventually it will decrease the GFR. Okay, in case of severe constriction, there is a graph plotted to show you that when there is moderate constriction of efferent arteriole, the hydrostatic pressure increases and GFR will increase than 120 ml per minute, which is normal value. But when there is severe constriction, the filtration fraction increases, and it will cause the remaining plasma to be concentrated with proteins, and eventually plasma oncotic pressure will increase, so GFR will decrease in case of severe constriction of efferent arteriole. So this was for today, and in the next lecture we'll discuss about more in detail about glomerular filtration rate. So I hope you understand this video.